Good morning, good afternoon, or indeed good evening. This is a short presentation on the musculoskeletal aspects of the hip. My name is Bruce Summers. I'm a consultant orthopaedic surgeon at the Princess Royal Hospital, and I'm also a senior lecturer in musculoskeletal medicine and surgery at Keele Medical School. And I should also add that I am the lead tutor for medical humanities, which might explain to you why there are a lot of what I would call very nice paintings, which I will hope will illustrate some of the orthopedic aspects that I'll be talking about. In the painting on this first slide, the lady in the middle with her back turned to us shows a very nice example of a test which we use in examination of the hip, which we'll discuss that again at the end of this talk. So we'll be talking about the anatomy of the hip, the pathology of osteoarthritis to a certain extent, the types of conditions which cause hip pain. We're talking about the symptoms that you get with hip pathology, and we'll be concentrating on, in fact, fractures of the hip and osteoarthritis of the hip. We'll go on to the slide which is entitled Anatomy, and this is an unbelievably unhelpful diagram of the anatomy of the hip. The reason for showing it is that it cost me about £150 about 10 years ago, along with a few other slides, so I thought I'd better use it, but it's too complicated, quite pretty in its way, but far too complicated. The next slide, which shows the bony anatomy, and really the anatomy of the hip is very, very simple. It's a ball and socket joint, it's a synovial joint. By virtue of it being a ball and socket joint, it's very stable. The ball is the femoral head, the socket is the acetabulum, and indeed the acetabulum is slightly deepened by the labrum, which is a fibrocartilaginous ring, which anatomically one wouldn't think is particularly important, but in fact it can be a source of pain, which we will mention a bit later on in this talk. Hip ligaments, from a clinical point of view, they're not particularly important. On the slide marked the acetabulum, you've got a quite nice view of the inside of the acetabulum, and that funny looking ligament there is called the ligamentum teres, which is a bit of an annoying ligament when you're operating, because it sort of holds the femoral head inside the socket, and it's quite hard to cut, and you have to use some very thick scissors to cut that in order to dislocate the hip to do your operation. In fact, the most important thing about the anatomy of the hip is the blood supply. This is because the blood supply comes from one direction only. That's from the base of the neck, and it runs up under the capsule and enters into the head. And there's obviously no blood coming in from the other direction, apart from a tiny amount of blood coming through the ligamentum teres. Now this has very substantial clinical significance, because if you have an intracapsular fracture of the neck of the femur, it can interrupt the blood supply, and if you haven't got a blood supply coming in the opposite direction, then you can lose the blood supply to the femoral head, and you then develop this condition called avascular necrosis, and the femoral head can collapse down and cause osteoarthritis and pain. With regard to the nerve supply, you don't need to know too much about the nerve supply of the hip. I put it in really just in order to show you really a picture of a surgeon from Guy's Hospital called Hilton, and Hilton in the 19th century developed this law, which obviously we called Hilton's law, which we used to have to recite when we were young medical students. And the law goes: the nerve which supplies the joint also supplies the muscles which move the joint. So you could have put that the other way around. So the nerves which supply the muscles which move the joint also supply the joint. The easy way to look upon it is that any nerve that goes anywhere near the joint sends off a little twig towards it. Now, the next slide does show something which I consider to be very important, and that this is regarding the pathologies which affect the hip. But in fact, everything else, not just in orthopedics, but in every aspect of medicine. So this is about the surgical sieve, and there are a lot of mnemonics which you've been taught, I think, or come across about pathologies which cause disease or which cause symptoms. But to my mind, this is the best one, and it's called timid medic. And so I want you to, and you can remember this by thinking of being on a ward round, and there's the fearsome consultant, and there's all the registrars there, and the senior registrar, and the nurses, and there's you as the timid medical student, and suddenly the consultant turns to you and points at you, and there's a patient with a swollen knee, and he says, "Tell me, what are all the causes of a swollen knee?" And without hesitation, you say trauma, infection, malignancy, inflammatory, degenerative, metabolic, emotional, doctoring, idiopathic, and congenital. And he will fall flat on his face in amazement. So that's timid medic. And why it's good, I think, is because the timid part of it is the 5 most important. So trauma, infection, malignancy, inflammatory, and degenerative. That's the only 5 causes of disease and pain that you can think of. That will cover everything. I apologise for the one which says doctoring. I couldn't think of anything beginning with D, which meant iatrogenic. So it's got to be that, I'm afraid. But no mnemonic is ever perfect. So the next slide relates to musculoskeletal symptoms and signs, so not just about the hip. And basically the symptom signs, again, can be considered in a mnemonic, basically pain, incapacity, stiffness, swelling, and deformity, which is PISSD, and I'm not going to say what that stands for. But the 2 most important, without doubt, is pain and incapacity. The incapacity coming from the pain, and pain is the first thing, because most patients who come with a musculoskeletal problem come complaining of pain. Not all of them, but most of them do. And so pain is what we're looking for, and of course there is the classical Socrates mnemonic for that. And after that, you have incapacity, or the difficulties that patients have as a result of pain, and you've got the Plato mnemonic for that. And then there's the stiffness of the joint, there's the swelling, which may be of relevance, and then deformity. But those are the 5 symptoms and signs that you get with musculoskeletal problems. So coming back now to the symptoms of hip pathology on this slide. So it's pain, and the pain is felt obviously in the hip, but the hip's quite a wide area. And so the pain is felt in the groin, in the thigh, and down to the knee. And I think one of the things to remember is that the pain in hip pathology can sometimes only be felt in the knee. So people can come complaining just of knee pain, but the pathology is in the hip, which is why it is so important that anyone coming with knee pain, you must examine their hip. And when do they get the pain? They get the pain when they're standing and walking. It disturbs their sleep. And the stiffness in the hip will cause them difficulty putting on socks and shoes and cutting their nails. And that's one of the questions you really always need to ask in patients who think might have some problems with their hip. Swelling and deformity is not particularly an issue with the hip. So those are the signs, the symptoms. In terms of the examination, there is already a video on the KLE which I've done, and you can see me doing the full examination of the hip, which shouldn't really take more than 5 or 6 minutes. So we'll now come on to hip fractures, and as you can see on this slide, there are 70,000 hip fractures per year. I think since that slide was made a few years ago, there are probably more now, as the numbers are still rising.
Certainly at both hospitals, at the Princess Royal and Royal Shrewsbury Hospital, we get about 600 hip fractures a year. The length of stay in hospital is really quite a long time, as you see, between 17 and 30 days. And by and large, the overwhelming majority of these patients are very elderly. They're over 80. Most of them are female because of the osteoporosis being the main pathology here. And these are often fatal injuries, and certainly there's a 10% mortality within a few weeks of the injury, and certainly 10%, I would say, mortality while the patients are still in hospital, and a 30% mortality in the first year. And although that one can treat these very appropriately, only about half return to their previous level of independence, and most patients have some persisting hip pain. So a lot of these patients who may have been independent before suddenly find that they require a lot of assistance. Some have to go into care homes. Those in care homes looking after themselves sometimes need to go into need more care. So it's a big problem. Normally these hip fractures occur after a fall, and they usually present with severe hip pain. They're unable to walk, but about 15% of these fractures are undisplaced, and sometimes these patients present late because they are able to walk a little bit, or the pain may not be too severe. So anyone complaining of pain in the hip or who is elderly, who may have had a fall, even if they are able to walk, you must consider the possibility that they've got a hip fracture. So when you examine these patients, as I've said, the hip is usually lying in external rotation and is shortened, and any movement, active or passive, is very painful. It's also important that you remember that these patients are elderly. They'll have a lot of comorbidities, so the medical aspect of the examination is also very important. And in terms of imaging, a plain X-ray is usually all that you need. It's important to remember that a lateral view is also very important, as it's often you can't see the hip fracture on the AP very well. And as I've said, the X-ray may be normal, or may appear to be normal when you first, if it's undisplaced. And unfortunately what tends to happen is that these patients tend to get discharged from A&E back home, and then they return again a few days later, and then they get discharged back home again, and a week later, when the fracture eventually displaces, the diagnosis is made, and you have an upset patient and upset relatives, and it all appears in the papers, in the local papers, that a patient with a hip fracture was sent home from casualty. So if someone has got a significant hip pain and the X-ray appears to be normal, you do need to investigate them a bit further. And probably the best thing to do is to do a CT scan, because they're quite easily available, much more available than an MRI scan. So a CT scan is likely to pick up a fracture, but even if this is normal and you're still querying a hip fracture, then in the old days we used to do isotope bone scans, but I would now then go for an MRI scan. And on this further slide you can see a CT and an MRI with fractures of the hip. How do we classify these hip fractures? Classification is important, because how you classify them will indicate how we're going to treat them. So we talk about intracapsular fractures, and you can see where they are. But we tend to call these subcapital fractures. And then the other two types of fracture are the trochanteric fractures, and where the fracture is between the trochanters, and then you have the subtrochanteric fractures, which are fractures below the trochanters. And both these types are extracapsular. And it's important because, as we discussed when we were talking about the anatomy, The main blood supply comes up underneath the capsule, and it's the only blood supply to the femoral head. So if you have a subcapital fracture, you're interrupting the blood supply. There's no other blood supply coming in, and so therefore the femoral head can lose its blood supply and develop avascular necrosis and collapse down. And on this slide, it shows an attempt to be made to, I'm sure actually a very good attempt to be made to fix the subcapital fracture, but the patient has gone on to develop avascular necrosis, and the femoral head has collapsed right down, and in fact one of the screws has gone through the femoral head. How do we then subclassify these subcapital fractures? Well, in the old days we used to do it with a garden classification of 1, 2 and 3, 4, but we've simplified it now into undisplaced and displaced fractures. So on this slide we have an undisplaced subcapital fracture with a low incidence of avascular necrosis, and on this slide we have a displaced subcapital fracture which has a higher incidence of avascular necrosis. Now the treatment for these subcapital fractures is quite simply an operation, and the only indication not to operate really would be if the patient refuses surgery, if the patient is completely moribund, that they would die at the first whiff of an anaesthetic or a spinal anaesthetic. And sometimes a patient with an undisplaced fracture will present very late, and after several weeks, they might, in fact, the pain might be improving, they might be walking reasonably well, and that situation is probably best just to leave well alone. So what are the operations? So the operations for an undisplaced subcapital fracture, in this situation the risk of avascular necrosis is low, so you can just fix the fracture with a couple of screws. That said, very often these days we would do a hemiarthroplasty, which is essentially removing the femoral head and replacing it with a metal prosthesis, because it's the bones in these elderly patients are very osteoporotic. And even if you put two screws in, it can wobble around a bit. But for the purposes of this talk and for the purposes of exams, if it's a subcapital fracture, if it's undisplaced, then you can fix it with two screws, or sometimes a dynamic hip screw and a plate. But you will often find surgeons just going straight for a hemiarthroplasty. If, however, it is a displaced subcapital fracture, then we would go for a hemiarthroplasty, which I said is basically removal of the femoral head, replacement with a femoral prosthesis, as you can see here on this slide and this X-ray. And this is because of the high risk of avascular necrosis. On this slide you can see that the right hip replacement has been cemented and the left has not. It is better, I'll put my head in the block and say that it is far better for the prosthesis to be cemented in and fixed in rather than just to be banged in without cement. If you put it in without cement, it'll wobble around and be painful, but it is a quicker operation. These patients are elderly and infirm, and that's the reason why they're put in without cement. You could do the operation in about 15-20 minutes, whereas with cement it might take up to 40 minutes or so. I still think it's better to do it with cement. Now, if you've got a subcapital fracture which is displaced and the patient is a fit patient, then what you mustn't do is do a hemiarthroplasty. The problem with the hemiarthroplasty is that you're only replacing the femoral head, you're not resurfacing the acetabulum. And what will happen is that that eventually the femoral head will grind its way through the acetabulum and wear the acetabulum out. Now, if you're a very infirm patient in their mid to late 80s, your lifespan is pretty short, you're not going to be very active, so the chance of you wearing it out and the chance of you outliving the prosthesis is small. But if you're fit, then we would want you to have a much longer lasting prosthesis, and we would certainly then go for a total hip replacement, as you can see on this slide here. So for the very elderly, subcapital displaced fractures, a hemiarthroplasty. For the fit, go for a total hip replacement. If, of course, in the fit patient you've got an undisplaced fracture, then you would still just fix it. And of course, in the very young, the question is, what do you do now? If you've got someone who is below 40, or even someone who is 25, 30, what are you going to do if you've got a displaced subcapital fracture? Obviously, in the very young person, again, if it's undisplaced, you would do just a fixation, but if it's displaced with the risk of avascular necrosis, what are you going to do? Because if you put in a total hip replacement in someone who's 25, it will wear out by the time they're 40. And then you're faced with a revision procedure which won't be as good as the first hip replacement. So in those situations, in the very young patient, okay, we would actually fix it even though there is a risk of avascular necrosis, and we keep our fingers crossed and hope that AVN doesn't occur. And if it does, then we've given it a shot. Then we'd have to go and do a total hip replacement. But some of these don't develop avascular necrosis. So we move on to the extra capsular fractures, the trochanteric fractures, and here is a slide on the left-hand side of a trochanteric fracture. In the extra capsular fractures, the trochanteric and subtrochanteric, there's no risk of avascular necrosis. And again, the operation here, the treatment here is surgery. And you would fix it usually with a dynamic hip screw, as you can see on this X-ray here. The subtrochanteric fractures are really difficult. They're often comminuted, they are unstable, and they can be very difficult to reduce and fix. It's a big problem fracture, and I must say I never liked having to deal with these. And they're very different. There are lots of different fixation techniques. And you put a nail down and then a screw across, or you put a long plate on, a long plate DHS. There's lots of different ways of doing it, but they are difficult fractures. Now, I want to say just a little bit about the soft tissue labral tears of the hip. Because there is a sort of general lesson to be learnt about these tears and how they present. If you remember, the labrum is the rim around the edge of the acetabulum. It's fibrocartilaginous, and they can tear. And when it tears, it causes groin pain, and it often occurs in quite sporty young adults. Now, the problem is that it's very non-specific presentation. The patient just says, I've got a pain in my groin and I can't do sport. And the X-ray is normal, and an MRI scan is normal. So often these patients were being labelled as being psychogenic, psychological, and often there were sort of patients who liked doing sport, and it was thought that they weren't getting into the teams, and this was a way out of explaining why they weren't achieving in their particular sport. So they would develop a pain which would explain why they weren't doing well. And it was discovered maybe 25, 30 years ago that in order to show the tears, you had to do an MRI arthrogram. In other words, you had to inject dye into the hip and then do an MRI scan. And that was the only way that you could diagnose it. And so we realized then that there was a genuine reason for these patients who were initially labelled psychological. And most of these patients do get better with conservative treatment, with physiotherapy and time, etc. And then surgeons got excited, and at this time the procedure of hip arthroscopy was being developed, and you could look inside the hip, and lots of various operations were being devised and are still being done now. The problem is that it was then discovered, of course, that patients without pain have labral tears if you do MRI scans and arthrograms on them. So we have this problem too, that just because someone has got a groin pain, and because you can demonstrate a tear, it doesn't necessarily mean that they've got pain due to the labral tear. And I just worry that a number of unnecessary operations have been performed on these young people on the basis that the pain was coming from the labral tear. So I don't know what the lesson one learns from that, except to say that just because we can't diagnose what the cause of pain is doesn't mean to say that the pain is not genuine. And I suppose the second lesson is just because there is pathology found on investigation doesn't mean to say that the pain is coming from that particular pathology, because there's an awful lot of imaging pathology seen which is asymptomatic. My son, Bryn, is a very sporty chap, and also in the Reserve Army, developed groin pain, and we went through the whole process of hip arthrograms with him, and we discovered a large labral tear, and that got better on its own. And he's in that picture there. I don't know whether you can spot him. He's 6'7". So we move on now from fractures, and we're now going to osteoarthritis of the hip, degenerative hip pathology. A very common condition, a very debilitating condition, but with an operation which is usually very successful. That is the total hip replacement. Most osteoarthritis is primary. In other words, there's no obvious cause for it. It's probably genetic. You can get osteoarthritis secondary to other conditions, for example, trauma. It can be congenital. You can get it secondary to avascular necrosis. But most of it is genetic, or certainly primary. On this slide you can see a femoral head just after it's been removed, presumably during the process of a total hip replacement, and this is a very typical view of the femoral head in somebody with osteoarthritis. What would normally be a beautiful smooth cartilaginous covering is now pitted and eroded. So the pathology of osteoarthritis is essentially, initially it is cartilaginous damage, thinning of the cartilage, fibrillation, and then frank loss of cartilage to the point that you get exposed bone. And then you get secondary bony changes such as osteophyte sclerosis, bony cysts, and you get the normal nice smooth outer line becomes very flattened and the bone can collapse. Indeed, all these changes in the cartilage you can see and in the bone you can actually see on X-rays. And in terms of examination, really all you require is an X-ray, and maybe occasionally an MRI scan, but rarely, I think. Sometimes if you don't know whether the patient's groin pain is coming from their back or coming from their hip, then what we will do is inject their hip with a long-acting local anaesthetic such as Marcaine under image intensifier control as a diagnostic procedure to see if it reduces substantially their pain for 24-48 hours. And if it does reduce their pain by at least 50%, then you can say, right, well, a significant amount of their pain is coming from the hip, and then you can proceed to treatment with a hip replacement if you think the pain is appropriate. Now, the radiological features of osteoarthritis we've sort of mentioned, but it's worth mentioning again. It's reduced joint space, irregular articular outlines, sclerosis, which is thickening and hardening of the bone, which is seen as a whitened bone on an X-ray, bone cysts and osteophytes. So how are you going to manage these patients? Well, apart from being empathetic and explaining the symptoms and what have you, then certainly painkillers, appropriate painkillers, adaptation of lifestyle to a certain extent. So we talk about loss of weight, although that's often difficult to get patients to actually lose weight. We talk about using a stick. But patients are very often not keen to use sticks because it makes them look disabled, but a stick may well be very helpful. Certainly do not inject the hip with steroids because you might introduce infection, which obviously would spoil the chance of a successful total hip replacement. And then the main treatment for established osteoarthritis, by established I mean someone who's got severe persistent pain, would be a total hip replacement. And a total hip replacement, as you'll see on this slide, is essentially resurfacing of the acetabulum, replacing it with a polythene implant, a polythene cup, and then removing the femoral head, and then replacing the femoral head with a metal prosthesis and a stem. And the components can be fixed with an acrylic cement. The acrylic cement is the cement which dentists use for filling teeth. It's not cement which is used in the building trade. And using cement, then you can fix the acetabulum and the femoral prosthesis very adequately. But for various reasons, 30 years ago, a vogue for putting in uncemented prostheses became popular. In this situation, you have to get a very, very tight fit between the prosthesis and the bone, and the prosthesis is in fact covered with a very rough surface, and the idea is that the bone actually grows into the rough surface and fixes the prosthesis to the bone that way. That's fine if you can get a very, very tight and accurate fit of the prosthesis to the bone. And you can do that with the acetabulum, but it's much more difficult to get the femoral stem to lie alongside the inside of the femoral canal. So what a lot of my colleagues do now is they put in an uncemented acetabulum and they cement the femoral stem, and they call this a hybrid prosthesis. And I should say at this point there's absolutely no evidence that there's any benefit from an uncemented prosthesis compared with a cemented one. With regards to cement, on this slide, just to explain a bit further, there's a powder and a liquid, and you mix the powder and the liquid, and a exothermic, very hot reaction occurs, and this doughy soft mix becomes hard in about 10 minutes. So you have about 3 or 4 minutes to get the cement either into the acetabulum or down the femoral canal, and then the cement, and then the prosthesis into where you want to put it, and then you have to hold it there very still until the cement goes hard. I just wondered whether the reason why surgeons started putting in uncemented prostheses was that they just became bored standing there holding the prosthesis in position for 10 minutes during the operation. I used to use that as a moment for reflection and chatting with the nursing staff and telling a few jokes, reciting poetry, that sort of thing. Anyway, back to hip replacements. So, and this slide on hybrid hip replacement shows a cemented femoral prosthesis and uncemented acetabular prosthesis. So, why is a hip replacement so successful? It's because it relieves pain, and it relieves pain in many patients almost totally, to the point that they have completely forget that they've had a hip replacement. It's important to know that the range of movement of the hip is not necessarily improved. If you have a very, very stiff hip before the operation, then the range of movement may be improved, but often patients have quite good range of movement, and in fact the hip replacement might stiffen the movement. or reduce movement, but that's not a problem. If it takes away their pain, then they're quite happy. Some patients with hip arthritis have a short leg, usually 2 or 3 centimetres. We do try and equalise the leg lengths, but it's not always possible. And sometimes actually you can lengthen the leg a little bit too much. In the UK, that's not a problem. In America, if you get the leg length wrong, then you are in for a big lawsuit. But there are complications. It is a big operation. The mortality rate is said to be less than 0.5%. That's the official figure. I would say really that our mortality is probably less than that. Infection is said to be less than 0.5%, and I would actually say it's probably a bit more than that. More likely to be in the region of 1%. And infection is a big problem. If it's a deep infection, then the hip replacement is lost, and you can't resurrect it with antibiotics. Superficial infections, yes, you can use antibiotics and you can recover from it. But a deep infection, you would have to do a major procedure to remove the hip replacement and then do a further complex operation. Dislocation of the hip replacement can occur early and it can occur late, and then it's just a question of reducing it under a general anaesthetic, and then trying to work out why that's happened. Sometimes it can happen early on because the muscles are just a bit weak, but sometimes it can happen because the acetabulum or the prosthesis has been put in a rotated position, in a wrong position. Obviously, you can get DVTs and emboli, and so patients get thromboprophylaxis, and nowadays they tend to have Fragmin, which they have for 6 weeks now, and they usually inject themselves at home. One of the complications too is obviously aperceptive loosening. The hip replacements don't last forever. I would like to think that most of them will last 15 to 20 years, but eventually they will loosen, and then they will become painful, and then you are faced with a revision procedure. There are other rarer complications. You can damage the femoral nerve or the sciatic nerve, or indeed you can go full house and damage both. That is pretty rare. You can fracture the femur when you're trying to dislocate the hip during the course of the operation. That's happened to me once. The sound of a femur fracturing during an operation is really pretty alarming. The leg lengths can be difficult to get right. And perhaps more importantly, if you've got a young patient, and it all depends on what you mean by young, they should be warned that the life expectancy, let's say 15 years, that they will need a revision procedure at that time. So it is not an operation for their whole life. So we have come to the end of this talk on the hip, and we've concentrated on hip arthritis and fractures. This beautiful painting you can see by Peter Paul Rubens in 1636, which is in the Prado in Madrid, shows the three Graces, who were minor goddesses in classical mythology, representing all sorts of things like beauty and happiness and whatever. But one of the reasons for showing it is that the middle lady with her back to us is standing on her left leg and her pelvis is tilted down. And so she's demonstrating a very classical Trendelenburg test. So whether that is due to an arthritic left hip, one's not sure. It might well be. We can't see entirely what her face is like, but it might be showing a little bit of pain. So that's the end of this talk, and if you have been, thank you for listening.